Hello, everybody. My name is Nelson Vergel. I'm the founder of Program for Wellness Restoration. It's a nonprofit I created in the early 90s to educate patients and physicians in the field of HIV about reversing and preventing wasting syndrome. Then we started working on educating patients on side effect management for the new drugs that came through in 1996. I've been living with HIV since '83, and I'm very happy to have been invited by the GRACE Project to speak about mostly wellness and health, but related to body changes and weight gain that some of us experience through basically the treatment of HIV. So I'll be basically reviewing all we know about it and what to do about it. So I hope you enjoy the presentation, and yeah, and if you have any questions, you can ask at the end of the conference. Just a waiver, just to allow everybody to know that this information is for basically educational purposes only, and in no way is a substitute for the advice of a qualified healthcare provider. So I'm just here reviewing some of the data and also the point of view of a patient living with HIV. So the agenda really quickly, and I have a lot to cover, so I'll try to be brief. I'm so sorry about how dense this presentation is, but I usually don't get a chance to speak to in conferences anymore. So it's basically an update of what I've learned in the past 5 years about weight gain in a new era of HIV, new drugs, the integrase inhibitor era. How to prevent heart disease, how to deal with the situation of increased visceral fat. I'll be speaking about what that means. Some healthy nutrition tips, some exercise tips, weight loss medication review real fast, a little bit on hormones and hormone balance, and the basics on sleep and why that is so important, not only for our energy levels, but for many, many other reasons, and a few resources at the end. So let's speak first about weight gain related to HIV medications and what we know in 2020. For those of you that have been around for a while, like I am as a long-term survivor, we have gone through a few changes in HIV and the way HIV attacks our bodies and how HIV medications affect our bodies. Before '96, as you all remember, and it really was a horrible experience, not only of our friends and family members dying, but also they were wasting away, losing a lot of weight and basically dying in bones. That's how I got motivated to learn more about this topic and to create my nonprofit program for wellness restoration. To actually reverse and prevent wasting syndrome, which really was one of the top killers of people with HIV before '96. At '96, we started seeing the introduction of protease inhibitors and non-nucleosides that started to change our life expectancy, and which was great. It was we got another chance to live. Excuse me. However, by '97, '98, we started seeing that there were some side effects that were concerning when it comes to body changes. Before '96, we're dying in bones and having wasting syndrome. But after '96, it was the complete opposite. We're gaining weight in very strange and different areas of our bodies. It was not just a general weight gain, but it was basically the accumulation of fat in the visceral, which is the deep organ cavity, and the cervical area, which is behind the neck. We used to call that buffalo hump. And those two accumulation of fat areas and the phenomenon is called lipohypertrophy, or the increase of fat. And that was mostly the boosted protease inhibitors with Norvir and ritonavir and all that. And also we had nucleoside analogs called thymidine analogs like AZT and Zerit that we were all taking along with protease inhibitors like Crixivan or Kaletra or saquinavir, all those. We also were looking at a strange syndrome of fat loss at the same time under the skin, especially the face. We have facial wasting as a main issue, and buttock wasting. And basically, a lot of us, men and women with HIV, we were getting very veiny. We would sear the veins under the skin while we were getting a belly due to visceral fat, and some people would get in that buffalo hump, which is the fat behind the cervical area. So those are really distressing. We had good news that we're living longer, but our bodies were really changing in a way that we were kind of terrified. Lipoatrophy, the fat loss under the skin, actually decreased a lot after Zerit and AZT were no longer recommended in the US in 2004, because those two agents were linked to that problem. However, lipohypertrophy, the fat gain, is still with us, not as severe as we used to have it. We don't hardly see any buffalo humps. The belly gain, weight gain is a little different. I'll be explaining what that looks like right now in 2020. Antiretroviral related mitochondrial toxicity, or toxicity to the little energy factories in our cells, was a big issue when it came to toxicities, for lipoatrophy related toxicities caused by Zerit and AZT, and protease inhibitors also caused the increase in insulin resistance, or the way our bodies actually metabolize insulin to burn carbohydrates and blood sugar and store it into energy in the muscle. So those are, along with inflammation, inflammatory cytokines, proteins that the immune system produces to fight HIV, were implied or implicated in this problem with lipohypertrophy and lipoatrophy. There were some genetic factors that were identified, but nobody really looked deeper into that data. Excuse me. The term lipodystrophy, believe it or not, we lived with that word for a long time. There were conferences related to lipodystrophy, papers, all that. But as time went by and nobody really found the solution of lipodystrophy, lipohypertrophy, I should say, this syndrome was later changed to the term return to health, which I'll explain whether or not that's an accurate way to name something that is disfiguring of the body due to fat gains. And that syndrome was associated with strong immune reconstitution. So that's where we are now. The word lipodystrophy is not used anymore in the clinical world or the conference world. Only the return to health syndrome, which is basically the same, but not as severe as years past. The only treatment approved to decrease or treat the increased abdominal fat is an injectable called Egrifta SR. I'll be, covering one or two slides on that. We really, back in the days when integrase inhibitors, maybe in 2008, I guess, I forget when the first integrase came in, which was raltegravir, Icentris. When it was introduced, we were really hoping that they did not cause weight gain, because they were not associated with mitochondrial toxicity or even insulin resistance, which were, thought to be the main factors involved in lipodystrophy, caused by protease and non-nukes, and nukes, mostly nucleosides. There were later, these integrase inhibitors were later found to actually cause greater weight gain than protease inhibitors in patients starting HIV medication, and also those that were switching from their old medications to integrase inhibitors. And a lot of us were switched to integrase inhibitors because integrase inhibitors do not increase cholesterol. They do not cause insulin resistance. They're actually more potent when it comes to decreasing viral load, and they're more effective, and they can be taken once a day. So there are many, many great things about this new class called integrase inhibitors that really made a huge difference. However, there was one thing that we were kind of really disappointed and shocked to find out in the past, basically 4 years or so, where the data has come out. The trend of the weight gain is actually more pronounced in women, African Americans, and people over 60 years of age, which is really a lot of us that are living long with HIV have been positive for 37 years, and I know a bunch of people that have been positive for at least 25. So there are a bunch of us in the United States, in the world, that are living with HIV for a long, long time. And we're exposed to a lot of the old drugs, and we're still dealing with the lipodystrophy situation. We have learned that all basically antiretroviral drugs can cause weight gain, and that patient-related factors may worsen their effect. Fortunately, and very happily about that, we know that disfiguring lipodystrophy, the one that basically created this huge belly increase and in buffalo hump, is actually rare now in patients that start integrase. They just gain weight, and some of it is obviously in the visceral area, but it's a generalized weight gain. And lipoatrophy, which is a wasting, the facial wasting, buttock wasting caused by AZT and Zerit, is rare to non-existent now. Although there's some developing countries that are still using AZT, unfortunately, because of cost. Many long-term survivors, as I said, are still dealing with body changes that were not really reversible like we thought. And the weight gain, this is one of the studies presented this year online, because we didn't have a face-to-face CROI conference, actually showed that weight gain after switching from either protease inhibitors to integrase inhibitors, or from non-nucleosides like Sustiva or a triplet to integrase. It's a little different. Among the graded weight gain was seen from the switch to integrase inhibitors from non-nucleosides versus protease inhibitors. And that's a little confusing, but in fact is non-nucleosides like Sustiva, Intelens, all those were really not associated with much weight gain. So obviously when we switched people got switched to integrase from non-nucleosides, which is NNRTIs, their weight gain was more pronounced, but really it's also because NNRTIs didn't really show as huge of a weight gain as PIs, protease inhibitors. But among those that switched from non-nucleosides, like I said, from a triplet to, let's say, TBK, dolutegravir, the analyzed weight gain was greater for females, non-white, older people living with HIV, and those switched to TBK, DTG, dolutegravir, which is an amazingly effective treatment, probably the best protease inhibitor that has come to market. And yet we were surprised to see that switching people from the old drugs to DTG to dolutegravir caused more weight increase than anything else. And I just wanted to show these confusing graphs. This is body mass index, younger and a little older, but still very young people. Body mass index on one side, and time since they were switched to integrase. And this is before they were switched. 0 is before, and 0 is after. And I just wanted to show this very busy graphic, because just to see that everybody's different. Every curve is a different patient. And so actually some patients had a decrease in weight. Some of them have an increase. So the generalized term a statement to say that everybody gains weight is not really 100% true. This is basically a trend after you average all values, but they are people that don't gain weight or even lose weight after switching. So I just wanted to make that clear, that it's not everybody, and it's not, but obviously if you averaged every piece of data, there's a little bit of an increase in each case. Excuse me. And this is the NA Accord study, a huge, huge study that followed, in this case, followed people from 2007 to 2016, almost 10 years. And they saw definitely a predicted weight increase higher on integrase inhibitors than protease inhibitors than non-nucleosides. Okay, and if we compare all the integrase inhibitors, dolutegravir or TBK compared to raltegravir or Icentris or bictegravir in Biktarvy, they had different also weight gains. So among integrase inhibitors, there's also a little bit of a difference in this cohort at least. And this line down here is non-nucleosides, which tend to also create weight gain, but not as severe as all the other ones. And this is a mean in advance. This is another study presented last year, the advanced study, which is a mean weight gain by sex and type of antiretroviral. Women tend to have more weight gain than men. So that's something you can see right away. And those taking dolutegravir and the new tenofovir, the new Viriad, the one that doesn't cause as many kidney or issues or bone density issues, called alafenamide, which is TAF. This is dolutegravir plus FTC, which is Entriva plus TAF, compared to Entriva plus tenofovir. So those with when switched to Truvada or started to the new TAF, gain more weight. So not only protease inhibitors like DTG can increase weight, but also the tenofovir, the Viriad replacement drug, that is actually more friendly to the kidneys and bones, but obviously a little bit more enhancer of weight gain. Excuse me. Drink some water. Sorry, I cannot see you while I'm doing this lecture. It's talking to a screen, so it's a little more not as exciting, but yet I'm very happy to be able to be sharing this data that most patients don't know about. And I understand why we haven't really educated patients on this, because it is frightening and fearful, even though to talk about this, because these are great drugs. And integrase inhibitors have really been the game changers of the field. So that's why my goal today is to speak about, hey, how can we manage this? How can we take our integrase inhibitors, which are really good for viral control, and try to minimize or manage this in the best way we can, even though we have very little data on interventions or weight gain related to integrase or other drugs. So this is not only just a weight gain in general, but they actually did an analysis of body composition. So they could actually tell, and this was a oral abstract presented this year at CROI in February, and they actually measure body composition with in people that were taking dolutegravir, which is TBK, and TAF and FTC, versus those taking the same drug, dolutegravir, with tenofovir, the Viriad, or Truvada, you call it, with Entriva, and those taking basically this is a tripla. So, and this is visceral fat. I'll speak about what that means. Is fat really deep inside the organ cavity. So not only is the weight gain that we're seeing with dolutegravir, but there's also a difference here in visceral fat with a tripla, and there's also a difference between TAF and Viriad or tenofovir when they're taken with dolutegravir. So it's interesting. It is not the increase of visceral fat that we saw back in the days of lipodystrophy. I have to be clear, but there is, there is an increase, although it's not as explosive and as dramatic as what we saw before. And we'll see. I will talk a little bit about why that's the case. And this is the $1 million slide, because nobody has really pinpointed why this is happening. A few studies presented last year and this year. And I'm glad to see that researchers are actually really now spending more research time on this question of weight gain. Now that we have done, companies have done a great job at looking for drugs that are effective and not as toxic. Now we have this lingering thing that we have to deal with. So I'm glad to see more and more studies coming through, but they're all small. And in the case of how many regimens containing integrase or TAF cause weight gain, they're proposed, obviously, hypotheses or predictors. They're integrase side, and this is TAF. Integrase may be affecting the genes associated with obesity. They may actually induce the creation of fat cells. There may be a better GI, gut tolerability, so I guess people don't lose as much weight. There's a reduction in inflammatory markers that may be catabolic or destroying of muscle and fat. Don't know. Potential correlation with lower energy expenditure. Maybe our bodies are using energy, using up less energy, and we, obviously gain fat when that happens. These are all hypotheses, and you can see there are a few studies are presented about that. On the case of the replacement of tenofovir, tenofovir actually makes a mild weight suppressive effect. So they say that maybe tenofovir actually helps not to make us gain weight, but also TAF tends to increase cholesterol, LDL cholesterol, unlike tenofovir, which doesn't. So TAF maybe amplify the weight gain effect of the dolutegravir. That doesn't really explain why this is happening, but at least there's some hypotheses that they're looking into. And these are different types, levels of BMI, body mass index. Body mass index is calculated by getting your weight in kilos divided by height square in centimeters. And we can go anywhere BMI of 22 to BMI of 40. BMI of under 25 is supposedly normal body weight. And this is a woman that is 5'4" tall, more or less the shape. And overweight is anybody with BMI over 25 to 30. Mine is 30, but I work out a lot, so it's muscle. So BMI is kind of not the best way to measure body, obviously not body composition, because you can have a high body weight, but more muscle than anything and still have a high BMI. So it's an easy way to measure something without having to go through expensive body composition analysis like DEXA. So BMI 25 to almost 30, 30 and so obese. This is overweight, obese class 1, obese class 2, and morbidly obese. And most Americans are in these three groups. 60% of Americans are in these three groups, believe it or not. And we'll see why. I mean, in the 60s and 70s, we didn't have that much of a problem as we do now. So there's few hypotheses, and this is everybody. This is not only HIV. I mean, everybody, HIV negative, positive, women and men. We're getting fatter. We're also getting more sedentary. And we're eating a lot more processed foods with high content of sugar and salt and et cetera, et cetera. So it's a combination of factors that are actually creating this issue for most Americans. And I'll be speaking about the effects of BMI on health in general. So as BMI goes up, and these are comorbidities like diabetes, asthma, arthritis, high blood pressure, and cancer. And these are the different colors are the different BMIs. As BMI goes up, you can tell obviously that comorbidities, all these problems go up. Okay. So, it's not only, oh man, I'm overweight, I'm obese, but it's also the fact that we do tend to develop more health issues when we are gaining weight over what's considered normal. And on survival and actually longevity, and this is not HIV, by the way, this is general population data. The different colors are years of people observing, like for somebody 20 years of age, and they have a BMI, you can see, for instance, let's pick a BMI of 39, excuse me, and these are the years of life lost. So obviously the younger you are that you spend being obese, the more years of life you're gonna lose. Okay, so that makes sense. So obviously the green, because it's younger people. If you're 20 and you have a high BMI, obviously you're gonna lose a lot more years of your life because of your health issues and so forth. So that's all. Longevity has a lot to do with the BMI and how long or how early in your life you started with a high BMI. And obesity in general can increase the incidence of diabetes, heart disease, colon, breast, gastric, pancreatic cancer, osteoarthritis, sleep apnea, hypertension, stroke, this high cholesterol, infertility, and all their issues. And people are sometimes not getting the help they need from their doctors, and people are spending a lot of money trying to lose weight, buying prepackaged foods, supplements that actually don't work. spending money in weight loss clinics, nutritionists, personal trainers, taking appetite suppressant drugs, surgery, liposuction, etc. So how do we prevent heart disease, which is connected to body weight, obviously? And there's such a thing called the metabolic syndrome that a lot of us with HIV have, and it's a presence of not only and sometimes not really high body weight, but insulin resistance, meaning insulin is not able to do its work. There's a resistance of cells in allowing insulin to grab glucose and store it in the muscle as glycogen, which is a source of energy, a storage. It's almost like the fridge our cells contain with this glycogen. So insulin bounces back and more glucose stays in the bloodstream, which the liver converts to triglycerides, which is really fat, dissolved fat, that ends up in not only in the liver as fatty liver, but also feeds fat cells everywhere under the skin, in the visceral area, etc. So, and the same insulin resistance causes obviously increased insulin because the pancreas is trying to control the higher glucose blood sugar that can actually be toxic to your brain. So when we have high insulin and the liver is actually trying to convert all that extra glucose into triglycerides, our cholesterol goes up. We may actually, because our pancreas gets eventually so fatigued and run down, we may actually stop producing insulin or have so much insulin resistance that our insulin doesn't work anymore. So we have type 2 diabetes, which is very different than type 1, which is a genetic problem. It's a family history issue where you're born with a type 1 type of diabetes. High blood pressure, all that combined can increase heart disease. And yes, there's some studies that show that we do tend to have a 20-some% increase in heart disease in HIV because we were, especially the ones like me, the long-term survivors that were exposed to a lot of the drugs that cause all this, insulin resistant, high insulin, high cholesterol, etc. The interesting thing about integrase inhibitors is that they are not known to cause insulin resistance or high insulin or high cholesterol, and yet we have this fat accumulation issue. So there's a disconnect there on some of the old explanations that we used to be hearing in conferences. And the highest risk for anybody to have coronary heart disease is high LDL cholesterol, low density lipoprotein over 130. If you smoke cigarettes, you have high blood pressure over 140 over 90, or even on blood pressure meds, HDL, which is a good cholesterol, high density lipoprotein under 40, and a family history of early coronary heart disease, especially if you had a family member, father, mother, grandparents, male under 55, or your female, your grandma, your mom under 65 had a heart attack or issues like that. So you have genetic predisposition to heart disease. And diabetes is also very well known as a risk factor to CHD. So how do we try to minimize this issue that not only affects us in HIV, but also in the general population? First of all, do not smoke. That's the number one and the easiest, not the easiest, it's hard for a lot of people to stop smoking. We do have some drugs that may help with the cravings, but do not smoke. Exercise and avoid a diet rich in sugar and simple carbs. I'm going to speak a little bit about diet. We were focusing on fat in the past 20 years, which really led to where we are now. And we forgot that the companies were extracting fat to make low fat or fat-free foods, were replacing that fat with sugar and salt, which eventually made us all fatter. Excuse me. Fat is not really big of an enemy as we used to think, and sugar, simple carbs are the ones to blame in many ways for high triglycerides and weight gain and insulin resistance. So try to lose weight if you're overweight. Obviously, that's easier said than done in most cases. We have to manage stress. There is a very strong link between high stress and cardiovascular disease. and those also harder said than done. Some of us learn how to meditate, learn how to do breathing exercises. Exercise can be a great way to manage stress, going for walks, listening to music, even talking to a good friend, and not watching the news as much as most of us are, because the news are in this country and around the world tend to be negative. Managing blood pressure, and many people with HIV are having blood pressure issues. So there are a lot of medications. Some are friendlier than others when it comes to side effects. The ACE inhibitors, the ARBs, tend to be friendlier when it comes to that. So a lot of us are on blood pressure medications. The higher the blood pressure, the higher the risk of heart disease, and also higher risk of dementia in later years. Triglycerides are the food source of fat cells, and we don't have as big of a problem as we used to. Protease inhibitors, Kaletra and Orvir, were really, really bad at increased triglycerides. That's why they're no longer in use, and they were replaced basically by integrase inhibitors, by non-nucleosides. Like triplosustiva did not cause triglycerides problems, for Kaletra, Crixivan, Saquinavir, all of them did. And some people take fish oils or omega-3 fatty acids, since they tend to help decrease that. Some people need extra medications beyond that supplement. Improving the good cholesterol is really hard to do. In HIV, we had issues with, even before medications entered the market, we had low HDL. Nobody really explained deeply why the virus decreases the good cholesterol on its own. It's maybe an inflammatory thing. And there are supplements like niacin that could probably increase HDL, but some people experience high flushing and feeling hot, and their skin feels like itchy, so they can't tolerate it. And they say taking an aspirin, a baby aspirin before that, may minimize these issues. Consuming soluble fiber, oats, anything that has fiber in it, I'll show a little bit on that, has been shown to decrease insulin resistance. If everything fails, obviously having your doctor prescribe a statin or fibrates, although some of these medications may have some side effects, like high CPK, which is a muscle destruction related issue in some patients. But that's one of the area of medicine that doctors are very highly educated on. Baby aspirin, 81 milligrams, anything higher than that can cause internal bleeding and issues with the stomach. So it's actually a blood thinner. And talk to your doctor about lipid-friendly drugs. And as I said, most all integrase inhibitors, non-nukes, which are a lot friendlier when it comes to cholesterol than the old drugs, protease inhibitors, which a lot of people have been switched away from. So this thing about visceral fat, what is that? Why is that important? Visceral fat, we have several types of fat. We have the subcutaneous fat, or fat under the skin, as you can see here. We have the visceral fat, the fat in the visceral area and where the organs are. You can actually pull with liposuction subcutaneous fat, but you can't really penetrate this deep area where there are more risks to puncture things by liposuction. And there's, excuse me, a fat basically in the back here. But this visceral fat has been linked to all health issues. This is a fat that actively produces proteins that affect blood pressure, affect cardiovascular health, triglycerides, etc. It's almost like another organ that grows inside of us. Subcutaneous fat is basically a protector, a storage of energy. We don't have the same metabolic related complications that visceral fat has. And that really has been the main focus in lipodystrophy, since HIV medications tend to exclusively, not exclusively, but greatly increase visceral fats compared to subcutaneous in most cases. So how do we actually see or know whether our fat is mostly visceral or under the skin? Well, one way to find out is to pinch your abdominal area and see how much of a pinch that is. Anything you can pinch is subcutaneous fat. You can see around here. Basically, what you go here, this is a one slice CT scan on the L4, L5 area, belly button area, where you're basically seeing somebody's insides as a one slice. Like, and I've gotten actually this done myself. It's not covered by insurance, but um, you see this area here, this white is visceral fat. It's a fat basically in the visceral area where all the organs are. And this is subcutaneous fat. So a lot of us have very little subcutaneous fat because we lost it through the use of ACT and D4T, which is there in a lot of visceral fat. I do have visceral fat. I have to work at it. That's why I've read so much about it. I'm doing everything possible so that it just stays or decreases, although it's not very easy, to be honest with you, to be completely frank, to decrease visceral fat. Once you have it, you have to basically lose weight and exercise and go through different diets, and still it's not all completely removed. So this is another comparison basically between a person living with HIV with visceral fat and little subcutaneous fat. This is a lot of us long-term survivors, like I said, that were exposed to Zerit and AZT and protease inhibitors. And this is a person living with HIV that just has obesity, basically probably one of the patients that started treatment after 2006, where we were not exposed to all the other nasty stuff that were exposed in the past. So you see a lot more uh, subcutaneous fat and not as much visceral fat as this person here. So I would bet this person is probably more a long-term survivor, and this is more of a newly infected or infected in the past 10 years and treated in the past 10 years. And high visceral fat increases cardiovascular risk. You can see on obese versus non-obese, triglycerides are higher in people with higher visceral fat, and HDL is lower, the good cholesterol is lower. So those two factors may actually be implicated in cardiovascular risk. Potential interventions, what we can do, even though we don't have much. I mean, the research, by the way, the visceral fat is not only something that HIV positive people have to deal with, but people with diabetes, people with metabolic issues, anybody that you see with a beer belly, alcoholic people that have a high degree of consumption of alcohol, people with liver issues, hepatitis, chronic liver disease, tend to have issues with a lot of visceral fat. We have no data on low carb diets in HIV, but we're starting to really see anecdotal effects. I'm really a true believer that that's one of the best ways to decrease this issue. It may not be, some people may think it's hard to do, but I have to say, once you stick to it, you tend to get used to it and actually eat more healthy. I'll talk a little bit about it. Exercise, especially cardiovascular, which is, walking, treadmill, running if you can jog. I'm really not a friend of jogging because of joint issues that I have. But anything that makes you sweat, anything that increases your body temperature, anything that increases your heart rate above what we call a normal rate and sustains the heart rate increase for at least an hour has been shown to decrease fat gain and visceral fat, some pilot data. But as I said, we have no research in this area in HIV. It actually stopped. I think it's not because researchers did not want to research, it's just funding was stopped in the metabolic area. Weight reduction, decreasing weight in general decreases visceral fat that proportionally. Metformin, which is an anti-diabetic drug, a generic glucophage. There's some data that's interesting, especially men and women with HIV that have insulin resistance may benefit from taking metformin, and they may actually see some fat reduction. And there's a human growth hormone, releasing hormone, which is a Grifta, as I said before. It was the only product approved to decrease fat in the abdominal area. And the belly fat, as I said, more heart attacks at higher risk of hardened arteries, high blood pressure, cholesterol, insulin resistance, diabetes. But reducing VAT may or may not decrease these risk factors, which I'm not 100% in agreement with. This studies presented in 2011 but because that was back in the days when were not exposed completely to friendlier HIV drugs. So Egrifta is a growth hormone releasing hormone. It's basically a hormone that makes your pituitary gland produce your own growth hormone. And there's some data that shows that we may have low growth hormone production, amplitude of the production. So Egrifta, growth hormone in general has been shown to decrease fat in large studies, non-HIV and HIV. And growth hormone and the functions of growth hormone are basically growth hormone is produced by the pituitary gland, is processed by the liver as IGF-1, insulin growth factor 1, which is implicated in stronger bones, in fat loss, adipose tissue breakdown, um, and obviously the reduction of VAT fat. So that there's good data. It is, however, there are different disadvantages. You have to inject under the skin. It's a water-based product daily for it to work. So that in itself could be a problem for some people. It's a high-cost product, but yet can be covered by insurance or patient assistance programs for people with no insurance. This is the data that got Egrifta approved for VAT. And there are three groups: the people that stayed on the treatment for 52 weeks, people that were on treatment and that were switched to a placebo, and people that were on placebo that were switched to treatment. So the bluest people were staying on treatment. They had a decrease in VAT and waist circumference as time went by. And people that were in treatment and when switched to placebo had a weight gain after they were switched. So that shows that the drug actually works. And if you stop using it, things may actually return to where they were. And this is placebo, which, people were obviously increasing in weight with time. And then they were given the drug and obviously their fat decreased. So that's what got this study got Egrifta approved by the FDA years ago. And when it comes to exercise and dietary changes, there's a small study, 6-month study on HIV positive people, and they actually found that the combination of exercise and cleaner diet decreased blood pressure and also the waist circumference, our waist size. Metformin, people that with HIV that took metformin also and had obviously insulin resistance had also a decreasing weight and waist circumference. So I really think this is a cheap drug, a generic, that some people may actually want to consider discussing with their doctors. When metformin was combined with exercise, that combination actually was even more effective in decreasing blood sugar, not blood sugar actually stays the same, you don't become hypoglycemic, but insulin and the area under the curve. So it's good to basically combine, the best thing to do is to combine a good nutrition, metformin, and exercise. And if your insurance or your patient assistance can access Egrifta, that will be a four-factor great combination program that can really probably work dramatically. I wish somebody actually studied that combination. So let's talk about food really quickly. I'm obviously covering a lot of ground. And what is pre-diabetes? A lot of us HIV positive and negative around the United States are walking around. And I say HIV positive people. Really, this graph was from the diabetes center in Minneapolis in 2000. That basically is a general graph. This is fasting blood glucose. Somebody that basically is normal, has normal health glucose. This is actually impaired fasting blood glucose, 101 to 125. Their insulin resistance, insulin production looks normal, but then obviously glucose keeps looking normal on paper, and then you start seeing slow increasing in glucose. You also start seeing an increase in insulin production, insulin resistance. Some people can stay on this in this phase 10 to 30 years, and it's called the glucose intolerance. It's actually a test you can take where they give you a sugary drink and they measure your glucose at a baseline and then 2 hours later just to see what your curve looks like, to determine whether or not you have glucose intolerance or you're pre-diabetic. Because measuring blood sugar alone does not really tell the doctors anything. And those that have glucose intolerance for a while, for a few years, tend to eventually develop diabetes more. So a lot of people in the United States are walking in this group and may actually end up with diabetes. This is going to be a problem. It's already a problem in this country, but it's going to become even more so unless we change our dietary habits, and the food industry doesn't feed us so much processed stuff that is not good for us. So this is a traditional food pyramid that the government has been pushing for years, until recently they actually realized this is not right, where they were telling people to eat a lot more carbohydrates, mostly breads and pastas and refined carbs that have basically hardly any fiber, and increase actually glucose and insulin resistance. Fruits and vegetables, obviously, meats, and, 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 and milk and cheese, and then sweets at the bottom. So this makes sense, but this actually could be one of the sources of the most dramatic increase in weight gain that we've had. That, and the fact that a lot of fat became an enemy. You see fat here. This is basically a bottle of olive oil. It became an enemy, and if the fat-free craze basically made us fatter, because they replaced fat with carbs, sugar, and salt. That made it more appealing to eat those foods. So there are good carbs and bad carbs. The bad carbs are basically the pancakes and the sugars, and even the white potato with sour cream and all that. That tends to increase insulin and blood sugar really dramatically, and it tends to take like a few hours for things to calm down. Um, the carbs like fruits and vegetables, oatmeal, bread, only really high fiber bread. I really am not a fan of bread. I think bread is one of those things that we if we avoid, some of us may actually lose weight. And there's a controversy right now, but it's worked for me. It's worked for many people I know, and I'll be talking about the keto diet. But we have in the good carbs, the high fiber carbs, fruits and vegetables, we have a raise in insulin and glucose that is less pronounced, and obviously it may actually not increase fat and triglycerides as much. The Mediterranean diet has been popular because they have observed that countries around the Mediterranean tend not to have as much obesity, although that's changing as we speak, as they adopt more of that American type of diet in those countries, with more fast food companies coming through. But the Mediterranean diet is not really heavy on meats, and they have more vegetables, and even the bread is healthier, more vegetables and fruit, mostly fish and shellfish. So obviously they're cheese lovers in the Mediterranean area, and chicken and meats and sweets like beef and sweets are less pronounced. They drink wine almost every day, at least one glass, so in moderation, obviously, and lots of water. And this is more or less what it looks like. And the problem with a lot of us in the United States is that a lot of these these products require us to go to the grocery store more frequently, because they do go bad faster than processed food. But that's something that we have to change as we improve our diets. The fact that we need more fruits and vegetables, more seeds, and grains, couscous, and not even couscous, I'm sorry, and vegetables, and seafood. The keto diet, I'm definitely uh, I'm I'm a follower. I'm a bias. I have very strong biases for it, because I've used it myself, and I've seen dramatic changes in my belly and weight, and just bloating in general, because you are minimizing. Let's talk about what to avoid. Sugary drinks. I mean, a margarita, for instance, has a lot of sugar. White potatoes, obviously, processed foods like burgers and stuff, soda and juice, even soy, even beans, sugar, obviously, vegetable oils. They want you, this diet is mostly into olive oil. They even some fruit that may have a lot of sugar in it, low-fat foods, because low-fat foods are usually rich in sugar. Processed treats, obviously, factory farm meat and fish. and grains in general, mostly breads. um, this is basically all you have to remember. No sugar and no bread, no pasta, no junk food. Okay, and excuse me. So you see mostly olive oil, coconut oil, even butter is okay. Vegetables of all colors, meats of all kinds. I mean, it really is a higher fat, higher protein, higher vegetable contents of fish here. Most of the pyramid you can see is vegetables, and the meats are a big deal. The fats, mostly in cheese and butter, are also not minimized, and some seeds and fruits and berries. um, some people freak out, especially doctors and some nutritionists, about this, especially meats and bacon and high-fat foods of this nature. But this diet is actually showing very good results in weight loss and even cholesterol and triglycerides. I really hope this is an invitation to any researchers that may be watching this to do a study on keto diet and HIV-related weight gain and visceral fat, because I really think this is where you lose weight faster. Obviously, a lot of the weight that happens in low-carb diets is water loss in the beginning of the diet. So there is a dramatic change in weight in the first 2-3 weeks that really is mostly due to because you do tend to eat more on this diet and be less hungry because you're filling yourself up with more of a real food and not what we most of us are eating out there. This is actually a study, a very long, big study published at the New England Journal of Medicine, comparing low-fat Mediterranean versus a low-carb diet. And as you can see, the low-fat diet was the one where people gained, they lost weight at the beginning because any diet works in the first, and these are months, 3 to 4 months of once you start watching your calories. But then you have an increase in the low-fat diet people, which were still on a diet, and they've been being observed, and these are 24 months, 2 years, had a bigger increase. These are the Mediterranean diet people. And the bottom one is the low carb diet people, like mostly keto and all that stuff. So, at least in this New England Journal of Medicine large study, that was shown to be the case. So just in general, what your plate should look like, mostly veggies, some protein, and the carbs have to be high fiber, uh, carbs. I eat a lot of black rice that I buy at the grocery store, high fiber rice as my main source of carbs, quinoa, sometimes sweet potatoes, although you have to be careful because that's a little bit of a fallacy there that we think it doesn't have simple carbs, but it's got a lot of fiber. And mostly reduce fried foods and hydrogenated oils. Eat more fish, oils, fish-rich foods, even tuna, sardines, flaxseed oil. Use more olive oil, which is being shown to decrease inflammation. Minimize sugar and fructose. Fruit juices, sweets, corn syrup, high fructose corn syrup. And eat enough protein. We need protein to keep lean body mass and stay healthy too. Do not skip breakfast. Keep an eye on your sugar and refined flour products. So because breakfast that most people have in cereals and all that is really rich in sugar. So mostly don't be afraid of eggs. I eat eggs and black rice for breakfast. Sometimes I don't have any carbs, just eggs and coffee, obviously. But don't skip it because you've been basically fasting for more than 8 hours, and your body really needs the nutrients. And something we've seen is people that skip breakfast tend to overcompensate at dinner time, which has been shown to be more of a contributor to weight gain and also sleep disorders once you fill your stomach up so much before going to bed. Trying to eat smaller meals and instead of huge meals, especially large, try to avoid large dinner. Eat more almonds, walnuts, pecans, pistachios. They're good for your cholesterol, good for fiber. Eat fruits and vegetables of all colors. Try to avoid the real sweet ones. Minimize caffeine after 2 p.m. just because your sleep will be more impaired. And mostly spend most of your money in the perimeter of the grocery store instead of the middle aisles where all the processed and boxed and canned foods are. I put here just a list of groceries. I think you're all gonna get a copy of my slides. Exercise, basically exercise is the only thing, there's not a pill medication that can do all this, like decrease total abdominal fat, improve the way insulin works, improve glucose tolerance, increase the good cholesterol, decrease triglycerides and LDL, increase muscle mass, especially resistance training, improve endurance, strength, bone density, and mood. When they invent a pill that does all this, somebody will be rich, but I have a feeling this is something we cannot outsource to somebody else. It's something we have to do ourselves, unfortunately. And this is something I've been really enjoying lately in the past, during the COVID time, where I was sitting more in front of a computer and not obviously leaving the house and exercising. The gyms were closed for a while, so I decided to start walking. And in Houston, it's so hot that most of us don't walk, but hey, we had to get over it somehow due to this isolation. Got myself a step counter, which is free, a step counter app on my iPhone. It's called Pacer, and basically I track how many steps I take during every day, and Pacer sends me an alert every night. Hey, you took this many steps. So really, we should be aiming from at 5 to 10,000 steps per day. The 10,000 steps per day have been shown in some data, some articles, that it may actually be the amount of steps we need to do so that we don't gain weight. And rightly so. Ever since I've been tracking my steps, I definitely have not gained any weight, even when I cheat on my keto diet, which is every weekend. And it also asks you a few questions. The apps actually can start giving you advice on if you want to decrease weight. You can tell here all the goals here. So it's a very interesting. It's free. They do not sell anything, which is kind of surprising. And I like it. I love it. It sends you can say 7 days, 30 days, 6 months, or a year steps and your history and all that. There's some days where I really walked a lot, like 17, 18,000 steps. Cardiovascular exercise, anything that makes you sweat, anything that makes your heart rate go up. As I said, 10,000 steps. Take a walk every day. It's not only good during COVID, but for your mood and your mind. Listen to your music. That's what I definitely have. That's the only one of the few good things that have come out of this COVID era for me is now finally walking every day and not having excuses about it, instead of sitting in front of the computer all day. Do what you enjoy, bicycling, roller skating, whatever it is. Dancing is aerobic, is cardiovascular. It burns fat, it triglycerides, blood sugar, improves blood pressure. 20 to 30 minutes, 3 to 4 times a week is enough for many people. I work, walking for an hour every day, every morning, especially if you get up early. It's actually pretty refreshing. It decreases, like I mentioned before, blood pressure, LDL cholesterol, and weight. It can also help increase a good cholesterol, mood, bone density, and even improves the chances to not have dementia in older age. Weight training or progressive resistance exercise is good for increasing strength, bone density, and firmness in the body. As we get older, we start getting softer because our lean body mass decreases as our fat mass increases. Just use machines. I tend to not do free weights because of some issues I have with my back. Had nothing to do with the gym, but some congenital issues. 8 to 12 reps to maximum failure, meaning the weight that you can handle, and that means different things to different people. 1 hour sessions, 3 times a week, no more than that. 3 sets per body part. If you have no access to a gym, doing some home-based exercises like crunches, push-ups, and squats at home. Basically just getting up and down from a chair several times can work for many people. There's a good website here that shows videos on different types of exercises. So weight loss treatments, we have not a bunch, 1, 2, 3, 4, 5, 6 treatments. No, 4, 1, 2, 3, 4, 5. One was discontinued this year because of cardiovascular issues. These are all basically appetite suppressants. And some doctors are better at others at knowing the different profiles of each. I don't have much time to discuss them today. We just wanted to bring that up in case that you really have issues trying to limit your caloric intake, and there are different ones, and all of them have side effects of some kind. The way insurance companies pay for it is only if you have a BMI over 30 or over 27, and one weight-associated comorbidity, either type 2 diabetes, high blood pressure, or high cholesterol. If your doctor actually writes this in your chart, you may have a better chance of having it paid for. Yeah, this I said before. So the side effects is some of them may increase blood pressure and heart rate, dry mouth, constipation, insomnia, for men, erectile dysfunction, and or are basically self-limited and those related. Everybody getting on these meds have to do these requirements before you get a prescription. Is you have to have obviously high BMI to get a prescription. You have to have a cardiovascular exam, AKG, just to make sure your heart is okay, and your blood pressure has to be treated. If you have renal disease or coronary artery disease, some doctors may or may not want to prescribe it. So there are contraindications to these medications. Now I'm going to go through the table of different ones, weight loss, what it was approved for, how it works, warnings, because you can see it on your handout. And basically, I don't want to spend much more time than I'm already taken up. So when it comes to hormones, it's very important because some of us don't know the basics on hormone balance. And as we get older, obviously, we tend to lose certain types of hormones. And these are 20, 30 decades in people's lives. Everything basically goes down except insulin. As I said, insulin resistance and cortisol, which is the anti-inflammatory hormone produced by the adrenals, but it also is tied to higher fat mass. So you see estrogen, progesterone, testosterone, growth hormone, thyroid, everything tends to decrease with age. Basically, almost like nature is getting you ready to dissolve and die. And some clinics are now trying to at least balance hormones so that we can have a more productive life into our older years. In women, these are premenopausal and menopausal. Before menopause, obviously through the menstrual cycle, you have increases and cycles of estrogen. These are the days of the cycle. Testosterone bumps up around 14, everything types of bumps up around that time. And then you have another peak of estrogen, progesterone in the around the 21st, 20 some days. So obviously it's very hard for doctors to measure hormones in a premenopausal woman due to cycles and the fact that hormones change, and what is a hormone deficiency. Only really good doctors can actually pinpoint and treat premenopausal women with hormone replacement. But it is definitely more accepted and more easily provided to women postmenopausal. Estrogen decreases with years of life in women, and actually men too, and progesterone does too. In menopause, there is a very high level of estrogen compared to progesterone, but they're all basically stabilize. In most cases, women that are over 60 years of age have the same amount of estrogen as men do, as they lose all the other hormones. So doctors tend to, and their doctors, they're actually depending on your symptoms of menopause, tend to provide treatment. And there's some controversial data that I don't have very much time, and I'll show you a book that you can buy to read more because we don't have time today. But these are the symptoms of hormone deficiency during postmenopause. If you have low estrogen, you may have all these symptoms: headaches, hot flashes, joint pain, progesterone, and low testosterone, low libido, decreased sex drive, low mood, and lack of energy. So these are some of the symptoms doctors that are in the HRT, the hormone replacement therapy field, look at. And we've seen, I'm not going to go into details, but the HRT treatments can be associated with reduced total and visceral fat in women. It's actually a good study that was done with bone density scanning. An excellent book. I read it. I have to say it's the best book I've read on the matter of HRT in women. It's called Estrogen Matters. So you can get it on Amazon. It's done by MD and a PhD that have a lot of experience on all the misconceptions related to estrogen treatment in women, postmenopausal women. there's obviously women are like men, need testosterone and produce testosterone. The ovaries and the adrenal glands produce DHEA and testosterone in women, and testosterone is needed by women to keep lean body mass, sex drive, even mood and outlook. However, there are no FDA-approved testosterone products for women, believe it or not. And so when doctors do prescribe testosterone at low concentrations for women, they do so by using compounded gels, compounded creams from compounding pharmacies. Um, because there's no pharmaceutical grade brand name yet for women. This is a very much ignored topic on hormone replacement in women, even though testosterone can do wonders for women that are tired, have low sex drive, and low mood. And these are some of the symptoms of testosterone deficiency in women. Like I said before, fatigue, declining sex drive, lack of sense of well-being, concentration, or orgasmic dysfunction, arousal disorder, basically not feeling like having sex, depression, loss of bone mineral density, thinning of hair, increased body fat, and decreased lean body mass. Thyroid is even more of a problem. We have no data on HIV, but you could have a very low and sluggish thyroid or a very highly producing or hyperthyroid gland that can have different, obviously, symptoms, as you can see here. So, however, unfortunately, in this country and all countries, thyroid function is measured with a simple test called TSH, which can be very misleading, since people with a TSH that is considered normal, let's say 2 to 3, could actually have a low thyroid production, hypothyroidism, and only more intricate testing like free T3, free T4, and antibodies will determine that. And lots, I would say that, because I work now in hormone replacement therapy, that's my new basically mission. I have a company called discountedlabs.com where I sell blood tests without doctor visit, and also consult with many HRT and testosterone companies out there. And we see really the misdiagnosis, underdiagnosis of thyroid dysfunction in women and men being a big, big problem right now. So they're definitely there are different thyroid medications, a lot of them made by compounding pharmacies. Some of them are pharmaceutical grade that can treat low thyroid in men and women, and basically increase mood, energy, fat loss, etc., etc. I'm very concerned because a lot of people are living a substandard life, a very low quality of life, and they don't even know that they're walking around with a sluggish thyroid. And sleep is very important. We are not sleeping as well as we used to because we are hooked on our appliances, our iPhones and iPads, and we're exposing our eyes to blue light, which is disruptive to REM sleep. And we're obviously, as we gain weight, we have more sleep apnea. And this lack of sleep or poor sleep is connected to all these problems like early death, insomnia, depression, diabetes, memory loss, stroke, heart attack, hypertension, daytime drowsiness, fat gain, etc. For those that have a lot of snoring and they feel tired when they wake up, it's good to be sent to a sleep study for a potential diagnosis of sleep apnea. And there are different types of masks that actually pump air into your lungs so that your oxygen levels don't decrease too much when you're sleeping. And as we age, things change when it comes to sleep. Less deep sleep and more lighter sleep. We have more difficulty maintaining sleep due to arousals and awakenings. And sleep is less efficient and more fragmented. We wake up more frequently. And the internal biological clock shifts to earlier bed and wake time. So um, there's a change in every way. Older persons experience a higher prevalence of medical conditions, and we also take more medications that disrupt sleep and are associated with sleep issues or fatigue during the day. And we have so as we get older, we also have more sleep disorders. So sleep apnea is another thing that most of us are underdiagnosed or not diagnosed, and it only really the squeaky wheel gets a grease on this type of problems. If you don't complain, you will never be sent to a sleep study. as we sleep, hormones actually increase. Cortisol, melatonin, growth hormone, thyroid hormone, testosterone increases. If we don't sleep well, these hormones are going to be basically deficient in our bodies. The most important thing that happens during sleep is cerebral blood flow spikes. We actually have blood flow going onto our brains and actually clean up a lot of the junk that is built up during the day and pulled out to be excreted by the liver and kidneys. So that's the main issue, and that can keep us from having dementia and even um, Alzheimer's in some cases, depending on genetic predisposition. This is something I'm also hooked on. As I said, for some reason during COVID, I've had two apps that have made a big difference in my health, and it's becoming really popular for this. I think it's $46 on Amazon. It's called the WellView Finger Trip Blood Oxygen Saturation Monitor. You sleep, you put it on your finger, and it's hooked up to an app on the phone that actually graphs your oxygen levels through your sleep cycle and see how many times your oxygen dipped, because hey, maybe you have sleep apnea, you're snoring, and when we have severe drops in oxygen, we're starving our brains from oxygen, and actually that's what increases heart risk, heart attack risk, and dementia, et cetera, et cetera. Increases obviously fatigue during the day. So this is a good quick way to find out if you may actually have sleep apnea and be sent to a sleep lab. So I love this gadget. It's probably one of my favorites. And basically, the best way to have good sleep hygiene is to try to relax before bed, spend more time in the daylight, actually getting some sun in your face or your eyes. Don't read on iPhone or iPad, or even watch TV on TV in bed. Read a paper book if you have to. Have a very light dinner, not too late, because that actually has been shown to decrease sleep quality. As I said, avoid all the electronics in bed. They have blue light that affects your sleep cycle. Keep your room dark and cool. If you're having problems falling asleep, melatonin is a supplement. I take chewable melatonin that I get on Amazon because it works faster, and it's actually pretty efficient, pretty effective. Um, Try to go to bed and get up at the same time every day. That really is part of the sleep hygiene, and we tend to actually sleep better. Don't watch TV in bed, and stay hydrated, even though people are afraid to drink water at night because they get up and pee more often. And the last but not least is mental health. It's actually a survey done in 831 people with HIV. They're aged 50 years or older. It was recently published this year. And it was very disconcerting, to be honest with you, because 56% have been diagnosed with depression, 31 have been diagnosed with other mental health issues, 27% have been diagnosed with post-traumatic stress disorder, PTSD, 46% felt down or depressed, 39% felt lonely or isolated within 2 weeks prior to taking the survey. 25% went 24 hours without interacting with another person. So we have to be very careful, because it really is something that is affecting a lot of us as we get older. We have to somehow find more friends, and it's not a very easy thing to do through the COVID time, obviously, because we're all isolating. Try to, even if you cannot see somebody, call your friends, talk more. Try to avoid the news, have better sleep so your mood doesn't get affected too much. Positive, it's easy to tell somebody to be positive, but it's really a daily struggle for all of us to keep mindful of what we have, how long we've come along. We've been fighting this illness for so long, and we lose perspective of how far we've come to even stay alive and healthy like we are. And we lose. I do have a strong history of depression, family history, and myself. So I have to, it's a constant. It's like working out, like going to the gym. You have to make sure you stay mindful. I follow, I've read a bunch of books, and I follow the work of Eckhart Tolle, The power now, because he really has taught me to be more mindful of the self-talk that I have to myself, and how we have to avoid putting ourselves down. We can be the worst enemies. Some of depression can be clinically, can be related to our health, like low thyroid can cause depression, low testosterone, low hormones. Maybe we're broke. Maybe we just lost a relative to COVID. So there are many situational related depressions, and there are all the times when we look around, we have it all, and we're still depressed and feeling like we have no motivation. So we all have to find a reason to live, a message to live by, to get up every morning with something to do that is actually productive and beneficial, not to us only, but to the world. I really think so. I saw this somewhere, somebody texted to me like years ago, and I saved it. You can tell it's kind of blurry, but these are the 7 cardinal rules in life. I don't even know where this is from. I apologize. We have to make peace with our past so it doesn't screw up our present. Well, we've heard that before. What others think of you is none of your business. And some of us just live and afraid or worried about what people think of us or what they think of us. Time heals almost everything, and give it time. And sometimes I don't have the patience to grieve or give things time, and I want things quickly and I want to fix them now. Don't compare your life with the life of others, and don't judge them. You have no idea what their journey is all about. Stop thinking too much. It's all right not to know all the answers. They will come to you when you least expect them, especially when you're more calm and less stressed. No one is in charge of your happiness except you. And we all know that. I mean, we've been told. But years are going by. I'm 61, being positive for a long time. My HIV viral load was not undetectable until 7 years ago. We've been afraid of dying. We've been afraid. We have trauma. We are survivors, and we've done a lot of work to be here. So we have to keep that perspective. And smile, even if you don't feel like you don't own all the problems in the world. And sometimes it's just contagious to smile at somebody that may actually be doing worse than you are that day. All right, well, these are resources. I do have a Facebook group called Post Health, where basically women and men with HIV, we discuss things, and all you have to do is send an email. Do I have it here? What did I do? Oh, can't believe I didn't have. You basically send, and well, Google groups.io/g/post health, and you can join there. But you can also send an email, but I forgot to put it here. And I won't waste your time on that. But yeah, definitely Google Post Health group, and join us there. And this is a group for women in Facebook. It's not HIV related. It's mostly for hormone replacement therapy, called Women's HRT. You can also find it on Facebook. Well, thank you very much. And I'm glad that I've been able to share this. I'm sorry that I've gone a little too long, and hopefully we all have some questions. Thanks a lot.